Hi everyone, good evening. Welcome to NHCA infection control class. And today we are going to be discussing about surgical site infections. Okay. So what are we going to discuss? The types of surgical infections, definition types, recent management of SSI. Okay. In your infection control textbook, page number 65 is surgical site infections. Okay. So normally SSI, how do we consider SSI is whenever the infection happens within 30 days after surgery or 1 year in after an implant. Sorry for the disconnect. Yeah. So, and any implant, then it is within 1 year. Okay. These are the SSI criteria for CDC guidelines. Soft tissue or wound infections. They are third most reported nosocomial infections. 16% of all reported nosocomial infections and most common surgical patient nosocomial infection. Now, how does it happen? The surgery, trauma, non-trauma, local invasion can lead to a bacterial insult. It's a pool of bacteria that develop on the wound. Once present, then they initiate the host defense process. Inflammatory mediators arrive, and then you see the scar. As you can see in the picture, a normal wound will look, there won't be any kind of redness. And you can see in the second image, there'll be kind of redness. But if it's a deep wound, organ wound, there's a possibility that externally everything may look normal. Patient has fever, and you know there is something that is going wrong within the body. Here you see this is an improper infected knee surgery, post knee surgery. You can see the redness, swelling. Now, whenever we talk about wound healing, we will talk about the types. But before that, any wound, okay, there are three ways of healing. One is primary, then is secondary intention, and delayed primary intention. Primary intention, it's a small wound and it heals fast. Look at the picture. So there's a clean surgery, a clean incision. You do the suturing, and there's a small scar. That is primary intention healing. Now you can see secondary intention. The irregular gaping is there. There's a granulation formation, epithelial grows over the scar, and then over time it heals. And tertiary intention is big, increased granulation, and the late suturing with wide scar, which takes longer. Okay. Primary healing. So, which are the three types? Primary intention, secondary intention, and delayed primary intention. These are the three how wounds heal, surgical wounds. Now, as we discussed earlier, CDC guidelines less than or equal to 30 days of surgery or within a year in case of implants. Okay. Classification of surgical site infections. We all know there are three types as per the CDC guidelines. Superficial incisional wounds, deep incisional surgical site, organ or space surgical site. Okay. These are the three types of surgical site infection. What are the common source of pathogen? Pathogen is endogenous flora of the patient's skin. Already there are organisms present in your body, mucous membranes, hollow viscera. Therefore, the pathogens isolated from the infection differ from the normal pathogens. Sometimes you have your normal natural flora of organism which are there in your mouth, intestine. But the one which is contaminating your wound is an external source. Okay. See the superficial incision, how it looks. And look at the redness. Less than 30 days, involve only the skin or subcutaneous tissue around the incision. Okay. I hope I'm audible to all.
Yes, ma'am.
Okay, great. Then, in case of deep incisional surgical site, you see the picture. Fever to hoga hai. Fever to hoga hai, and there'll be localized pain or tenderness, purulent discharge, wound dehiscence. You can see the wound. Even a diabetic wound can be a deep incisional wound. Okay. After diabetic surgery, you might have seen patients. It's a deep wound and takes so much of time for healing. Now you see organ or space. Why this image? Because you cannot see. Sometimes this organ infected is internal. A kidney transplant. It is internally infected or rejected. But you can't see externally. The wound externally is good. Okay. So that is an organ or space surgical site infection. So as we discussed, superficial incisions less than 30 days and involve only the skin or subcutaneous. And deep incisional more than 30 days or 1 year in case of implants, which involves the deep soft tissues, fascia and muscles. Now, what are some of the risk factors? Okay, surgical factors, patient specific factors, and there are local factors and systemic factors. Okay, see, as you can see in this slide, high bacterial load, wound hematoma. These are the factors that are influencing surgical site infections. Patient risk factors, necrotic tissue, foreign body, obese patients. They are a higher chance for infection. Systemic, advanced age in the system of the body. Old age person, very delayed healing will be there. And specifically if he has diabetes or other kind of cholesterol, high blood pressure, if there is shock, malnutrition, alcoholism, if the patient is on some steroids, these all impair your wound healing because steroids will make you immunocompromised, right? Chemotherapy will make you immunocompromised. And immunocompromised conditions like transplant case, neutropenia, thrombocytopenia, all these conditions, if you have a wound, the chances of surgical site infection is higher. Okay. Now, even your antibiotics, what you give, that can influence your surgical site infections. The prophylactic antibiotics and the therapeutic antibiotics. Sometimes the right antibiotic is not given to the patient. Sometimes prophylactic treatment is not given. Nowadays, I have seen NABH and JCI accredited or other international accredited hospitals, they have a set rule for prophylaxis. But still in smaller nursing homes and all, sometimes they don't have this protocol. And therefore, because the prophylactic antibiotic is not given, there's a high possibility of surgical site infections. What are some of the surgical risk factors? The type of procedure, the degree of contamination. Now, type of procedure may be, certain surgeries like mastectomy, neck dissection. These are all clean surgeries. But abscess drainage, perforated bowel, these are all complicated ones and they're already dirty. So that can influence your surgical site infection. The degree of contamination. If a person has met with an accident, a lot of contamination and a deep wound, the chances of surgical site is more. Duration of the operation. The more you have longer operation, the chances of infection is higher. You see, he's more on the ventilator, intubated for a longer time. Neurological surgeries, bone surgeries, it takes time. Okay, so there's a chance of infection which is higher. The urgency of operation wherein you have not prepared adequately the patient. Skin preparation, operating room environment, if the terminal surface cleaning, fogging, fumigation is not done appropriately, and if the antibiotic prophylaxis is not given properly, that will increase your surgical site infection chances. All right. Now let's move on to the surgical classification. Typically, there are four types. It's there in your textbook also, page number 66. Clean wounds, clean contaminated wounds, and dirty wounds. Okay. You can call it as also class 1, class 2, class 3, and class 4 wounds. So the classification of surgical wounds, clean contaminated, and dirty wounds. Now, what are these clean wounds? They are uninfected. They're not infected. There's no inflammation. They are closed wounds. They don't enter the respiratory GI, GU tracts, not entered. What are some of the examples? Mastectomy, vascular hernia, laparoscopy, neck dissection, splenectomy. These are all considered in your clean wounds. Okay. Second is clean contaminated. Clean contaminated, in that what all comes? Gastric, intestine, appendix, liver surgery. So there is some contamination, but it's still a clean wound. Respiratory GI tract are entered, but it's controlled. No unusual contamination. So just see, in clean wounds, the percent of infection may be just 2%. And in such clean contaminated wounds, less than 10% are the infection rates chances. Now let's move on to the two complicated ones. Contaminated wounds, inflamed, appendectomy, bile spillage, diverticulitis, rectal surgery, penetrating wounds, open fresh accidental wounds, major break in the sterile technique. Okay. Now, gross spillage from the GI tract, non-purulent inflammation, okay, rupture. These all are contaminated wounds. There, the infection chances are almost 20%. Next is the dirty wounds. Dirty wounds, abscess, incision, drainage, perforated bowel, peritonitis, debridement of wound, positive culture, pre-op, traumatic wounds, devitalized tissue. These all, if a procedure is done and already the organism is present, they are all dirty wounds. Okay. How much can you clean an already present wound? Understanding. You can kill microbes. Some organisms cannot be killed. Spores cannot be killed sometimes. Bacterial colonization. You may clean up to 10%. Some percent will always be there. Okay. So these are the four wound classification: clean, contaminated, and dirty. Clean is class 1, clean contaminated is class 2, contaminated is class 3, and dirty is class 4. Now, now wound infection may be defined as a presence of bacteria or any organism which leads to a host reaction. Okay. So when a bacteria enters your body, what happens? Your body will try to defend it, try to eliminate it out of the body. And that is a host reaction. Now, how can the pathogens originate? They can originate through contact with chemicals, bacteria, virus, contaminated water. Now, I'm just explaining to you some of the terminologies. Contamination. One or two questions from this can come for your exam, okay? Contamination is the presence of pathogens on the surface of the skin or wound. No need to study that. Colonization. What is a colonization? Colonization means a lot of organisms, particular when you check sampling, you'll see colonies that are formed in a particular specimen. Bacterial colonization is the colonies that are formed in that specific one. Microbiology students will know much about it. The viral load, the bacterial load. Okay. So colonization occurs when contaminate multiply significantly and the body's immune system is overwhelmed. signs of inflammation become apparent: redness, heat, drainage. So we learned contamination, colonization. Now let's look at bioburdens. What is a bioburden? This image is a bioburden actually. It is the number of contaminating microbes. You have a wound, you cleaned it nicely with betadine and all. After that, when you check how much organisms are there, that is your bioburdens. Okay. A bioburden is a number of contaminating microbes, germs, pathogens on the surface. Okay. Biofilm. I just thought of the most easiest way for you to understand. So look at this picture. Looking at this picture, what do you feel? Biofilm is good or bad? This is a biofilm. Biofilm is good or bad? Come on, tell me. Message on chat box. Biofilm is good or bad? It's good. It's good. It's bad. That's why I took this page, this photo. This yellow thing, na, it's like a plaque which is formed on the teeth. I know you all might have thought it's a protective layer. It's not a protective layer. It is a layer which is formed by the organisms. So if I'm giving antibiotic in this state, it is not going to affect the root because like soldiers, the organisms are surrounded the tooth. Same, look at the, so same is with a wound, okay? So when you have a wound, open wound, and if there is a biofilm, that means the doctor has to scrub it off with hydrogen peroxide or any other solution nicely. If you must have gone to this government hospitals, you'll see how these doctors, they scrub, and the patient must be screaming and crying, but they'll scrub it, let the froth come out, and then they clean the wound. Okay, because there is biofilm present on the layer of the wound, which they need to scrub, and then they'll use the antibiotic. Otherwise, this biofilm is good for the organisms and bad for the person, bad for you and me. Okay, biofilm will come up for the exam. What is biofilm? It is the extracellular matrix structure that attaches itself to a wound surface, necrotic or living, and protects microbes from the host defense. So, who is it protecting? It is protecting the organisms. A biofilm structure attaches itself very firmly to the surrounding environment surface of the wound. The biofilm must be scrubbed off the wound simply with wound cleanser or pouring sterile water. Okay. But just putting that is not sufficient. You have to scrub and get rid of the biofilm. You have to cut it. You might have seen on these wounds some yellow color, pussy layer which forms. And what the doctor takes, he takes a sterile blade and cuts it off. When you cut it, then red blood comes. Red blood is a good sign that the wound is healing. So that's the way it is. Now, what are some of the indicators of local and systemic indicators of wound infection? You all must be knowing it. That's why I'm just reading it out. Redness, increased amount of exudate, change in the color, malodor, localized pain, localized heat, delayed or abnormal healing, wound breakdown. These are all your local indicators. Systemic, increased temperature, you will have fever, general malaise or weakness, leukocyte count will be high, and sometimes you will have increased WBC count. All these are indicators for increased systemic infection. Okay. Now let's move on to some management how we'll do. In surgical site preventions, I'm just telling you now, forget the book picture. Normally, what all are the things that we need to do for surgical site infections? First thing is isolation, compulsory contact, strict contact isolation. Okay. Then 1:1 ratio because it can cause cross contamination. All right. Second thing, the dressing, which has to be very strict. Don't expose the dressing open for a long time. And that has to be touched with a separate gloves. When the doctor is ready for the procedure, only then remove the dressing. Don't expose the dress open. Then antibiotic should be based on the culture reports. Whatever is organism, you take that particular result and then prescribe antibiotic. But the report count takes time, na 3 4 days. Before that, at least start a broad spectrum antibiotic. Then next, um, send things for culture, dressing protocol follow strictly, isolation protocol follow strictly, assess the wound constantly. Correct? These are the things that you have to keep in mind when it comes to caring for surgical wounds. Follow up care. Person has completed his surgery. Make sure you explain to him correctly how to take care of the wound so that he doesn't have to go home, then get infected and come back to the hospital. Preparation of the patient to prevent surgical site. Identify and treat all infections. Keep pre-operative stay as short as possible. Like tomorrow is a surgery. Don't call him 2 days back. Hospital is always a source of infection because organisms are running around in the air. So if tomorrow is a surgery, either tomorrow morning or today night, if it's a big surgery, because they need preparation of bowel and all that. Okay. Don't call before that. Some hospitals they'll call on a Saturday, Sunday waste in all investigation, then Monday surgery. Don't do. When required, only then call them. Then antiseptic bath at least night before and the operative day. Then all those things, razors, clippers. Don't use blade, use clippers because cuts can again be a source of infection. Apply pre-operative antiseptic skin preparation in a aseptic manner, clean to unclean. Okay, all these are coming under preparation of patients. In some of the places, they don't give that antiseptic bath. They just tell the patient go and take bath because the nurse is busy. She's having one nurse is having 6 to 7 patients. Array, you don't have to do. You are not giving bath. Relative or the patient is taking bath. They have that solution, right? Inform them. If you educate them, they will take that and put it in the solution wherever water is there. They are going to use to have bath because that is important. Okay. Antimicrobial prophylaxis. Antibiotic should be administered and efficacy should be monitored. Also, in the operation theater, when do you give the antibiotic? Once the patient comes to OT, when do you give the next dose of antibiotic? Anyone? Yes, thanks, Binya. So it's 1 hour before the skin incision, huh? Not before OT. 1 hour. Sometimes what happens, OT person is taken inside, full preparation done, antibiotic given. Then the doctor comes and says he'll come after 2 3 hours. There's no use of the antibiotic. It has to be given 1 hour before the incision. And there are fights between the nurses in the ward, doctors in the ward, and anesthetists and the OT nurses. You give antibiotic. They'll say you give, you give. But as per the rationale, it is to be given by the OT staff because they know within 1 hour is when. A ward person will always think of sending the patient fast to OT. Then their headache is over. Okay. So that is antibiotic prophylaxis. Monitor, give it on time. Whatever dilution and test dose has to be given. Cleaning and disinfection of the environment. Make sure that the room is really sterilized properly. Otherwise, what happens? Suppose you have taken a contaminated case and the terminal surface cleaning and all is not done. This patient will be at a higher risk for infection. Clean the operating room floor after the last operation of the day or night with an approved hospital disinfectant. Do not perform special cleaning or closing of OT after contaminated or dirty operation. Asepsis and surgical technique should be followed strictly. Okay. Then surgical attire and drapes, all that you have to follow strictly. Your hand hygiene, surgical wash, strictly following the OT protocols. Wearing a cap, hood, certain operations you need to wear the boots, all that has to be correctly maintained. Then post-operative incision care. Protect with a sterile dressing 24 to 48 hours post-operatively. Wash hands before and after dressing change. And whenever you contact the surgical site, always wash hands. Use sterile technique to change the incision dressing. Educate patient and family regarding proper incision care, symptoms of surgical site infection and need to report such symptoms. If you don't inform them, they will not understand. If there's fever, all this you have to inform. And also the last option, develop a good surveillance system to study the incidence of SSI. So whenever in your hospital there is an SSI, study that because so that you can prevent in future. Okay. Use standardized case definitions. Use methods for inpatient and outpatient case finding. Assign surgical wound classification. For each patient undergoing an operation, chosen for surveillance, record the variables. So, like basically, how you do your COTI, VAP, like that. Only for SSI, you have to do studies, root cause analysis, what happened, where things went wrong. Let there be a meeting. Okay. So, this is how you will try to reduce surgical site infections. So, today, what all we discussed? We started with the definition, right? Then after the definition, then we went on for the different types of healing. How do you heal? How wound healing takes place? Okay. Yes. Then SSI and types of SSI as per CDC guidelines. Then classification of surgical wounds. In classification of surgical wounds, we learned clean wounds, clean contaminated and dirty wounds. Correct? Then we learn some definitions of contamination, colonization, bioburdens, and biofilm. Then we discuss the local indicators and the systemic indicators. Okay. Then three types of surgical site infections. Then we went on to the surgical site infection prevention, how you prevent it in a hospital. Okay. Can anyone tell me last Saturday class topic? Saturday topic you will have to ask Anishma ma'am tomorrow. Regarding this topic, anybody has any doubts? I hope everybody is clear with it. So read this chapter. Just one or two questions will be there for exam from this chapter. Okay. But basically, you're reading all this for your personal knowledge. Okay. So, yeah, that's good. So, I hope so. Infection control is the most easiest exam and quality. Okay. So, those of you who have taken infection control or quality, start reading your books now. Now it's May, June, July, August will be your exam. Okay. So, have a weekend and yeah, tomorrow 3 o'clock, Six Sigma, 4 o'clock, quality, and 5 o'clock, infection control. Okay. And today, matlab Friday, every Friday 3 p.m. is hospital administration for those who have taken hospital administration. And 5 p.m. every Friday 5 p.m. is different subject depending on your subject. So I will be messaging you all only for Friday lecture. The others you don't get any reminders. You know that is a fixed time. Okay. So have a happy weekend. Bye bye. Take care, all of you.